So we are live, you can start.
Good evening, everybody. Greetings from Endocrine Society of India. We were celebrating the 50th Golden Jubilee of the Endocrine Society of India. So we are continuing with the patient education initiatives of type 1 diabetes awareness. This session will be focused on insulin journey across the lifespan. We have got a panel discussion lined up today for you. It will be moderated by Dr. Sri Nagesh, B. Sri Nagesh. Welcome, Dr. Sri Nagesh, sir.
Hello.
Sir is a consultant endocrinologist working in Hyderabad at Sri Nagesh Diabetes, Thyroid and Endocrine Clinic. He has been honored by so many laurels in his academic career, including fellowship of the EASD Scientific and also the AB Shade, AR Shade Best Paper Award, ESICON. He has got rich experience in type 1 diabetes besides all endocrine conditions. Welcome, sir. We also have with us Dr. Mohammed Shirwan. He is working as a consultant in Maldives. He is working in IGMH Maldives. He has trained in Malaysia and is doing a great service for the nation in Southeast Asia. Welcome, sir. We also have with us Ms. Usha Diman. Ma'am is the type 1 diabetes warrior, completed 32 years now ongoing with type 1 diabetes. She has been awarded with Dr. Mohan's Victory Over Diabetes Medal, New Delhi. And she's working in New Delhi, and she's retired from services, and now she's placed in New Delhi. And Madam has been vocal about the rights of type 1 diabetes. She's always helping us with a lot of awareness activities across the nation. Welcome, Madam.
Thank you.
To complete the panel, we have Dr. Vishnu Vasudevan. He's our buddy. He's working as a consultant endocrinologist in Perindalmanna Maudana Hospital in Kerala. He has been trained from SKIMS Srinagar and has also got a lot of vocal about the type 1 diabetes research, also focuses on a lot of connectivity on the national media. So welcome all the panel. Over to you, Dr. Sri Nagesh, sir.
Thank you, dear Mohan, and it's always a great pleasure and an honor to be a part of the present program. This is a program which is very unlike the previous activities which have been done by ESI, because this is one of our first and best attempts to reach out to the people whom we want to see healthy, the people who we want to treat. And we've understood that there are a lot of misconceptions, misapprehensions and misunderstandings about type 1 diabetes, which can be a very dreadful disease, not only physically, but also emotionally and psychologically for both the people affected as well as their immediate family members. With the advent of technology, the use of better insulins, so much of devices penetrating into the diabetes sphere, and so many preventive measures for complication, type 1 diabetes is not the lethal disease it happened to be a century ago. In fact, this particular year, we're actually celebrating the century of discovery of insulin. Prior to 1921, diabetes was a fatal disease. It is just a simple chronic disease nowadays. Treated appropriately, you can have a normal life with diabetes. You can have a normal lifespan with diabetes. And there are no severe dietary restrictions or any other restrictions on a lot of people with diabetes now. A perfect example of what I'm talking about is one of our panelists, whom we are privileged to have today, Ms. Usha Diman, who's lived with diabetes for the past 62 years. And this should come as a note of confidence for all those people out there who are living with diabetes, that in spite of having started out in an era when technology was and medical knowledge was not so well developed, she's managed to live 62 years without any complications, mind you, without any complications of diabetes. If she can do it, you all can do it. Only thing you would need is the amount of dedication and application she has towards her health. Follow her, and you'll also have an equally happy and healthy life with type 1 diabetes. Also, along with us, we are happy to welcome Dr. Sirohan, an endocrinologist from one of the SAARC countries, Maldives, which has a fairly high prevalence of people with diabetes. We'd be very happy to share his experience. And we have our dear friend Vishnu Vasudevan, who comprises of the youth component of our Type 1 Diabetes Initiative. He's going to give us the new technological perspectives. To set the ball rolling, I'd like to start with the youngest person, Vishnu. Vishnu, any questions you'd like to address to the panel or your observations on Type 1 diabetes?
Yeah, thank you, Dr. Nagesh sir. Good evening all. It's a pleasure to have an eminent panel to discuss a very important topic like type 1 diabetes. So as we were discussing before, type 1 diabetes is entirely different from type 2 diabetes. So people are always familiar whenever they hear the term diabetes, they think about type 2 diabetes and all the dietary or obesity related problems which are always associated with type 2 diabetes. It is a common one and people are always space country also. Type 1 diabetes is a relatively less common disease, and people who are affected with type 1 diabetes also face the stigma which is associated with type 2 diabetes. So this type 1 diabetes, how I, though this today's talk is regarding the insulin journey across the lifespan of it. Still, I would like to put forward this question as the first one. How can we address this problem of comparing type 1 diabetes or assigning the problems of type 2 diabetes on a patient who is newly diagnosed with type 1? So what are the opinions of the panelists? I think I'll hand over this question to Nagesh sir itself for the first introductory answer.
Okay. One of the first, this has been my experience with that one of the first questions which we are asked in the OB is, the patients ask us, do I have type 1 or do I have type 2? I keep telling patients that there must be more than 100 different types of diabetes and you can't simply differentiate it as a type 1 or a type 2. It's true that these are the two most common types of diabetes, but patients have always had this habit of comparing type 1 and type 2. I've seen a lot of situations where slightly older adults, some people who are in their early 20s, are often mislabeled as type 2 diabetes when they actually have type 1 diabetes. There's been a lack of knowledge on part of the doctors in labeling people with type 1 as type 2 diabetes. Second, I've seen the stigma with patients. Many patients don't like to be told that they have type 1 diabetes, people in their early 20s, early 30s, people with latent autoimmune diabetes. Because if you have type 1 diabetes, the only option you have left is insulin therapy. So rather than starting early on insulin therapy, in fact, people in their 20s, if they are diagnosed with type 1 diabetes, it's actually a lot easier to control the diabetes than somebody who's been diagnosed when he was 8 years old or 9 years old. Because you have passed through your teenage, your glucose fluctuations are down. You can just, in a majority of cases, you can be managed with only 2 doses, or in very early type 1, even once daily dose of insulin is also more than enough. Rather than aggravating the problem, but people don't understand the fact that early diagnosis and early initiation of treatment is what really helps a lot of type 1 diabetes. They get stigmatized. And this is something which we have to tell them, which we have to fight. We'll ask Mr. Dr. Siruhan about his experience in Maldives, type 1 versus type 2.
Thank you, Endocrine Society of India, for giving me this opportunity. What I have noticed is, as Dr. Nagesh has mentioned, it's very important to recognize that the age of onset of type 1 diabetes has an impact on the control and as well as the treatment. We know that patients who are diagnosed beyond 18 years of age, beyond their teenage years, they do have this lingering beta cell function for many years. In fact, some of the studies, major studies, landmark studies of type 2 diabetes have shown that actually, in fact, some of the patients may actually had type 1 diabetes from the autoimmune. So as Dr. Nagesh has mentioned, just because you are given a diagnosis of type 1 diabetes, the treatment may actually be different for different type of patients. because there are different challenges which people with type 1 diabetes face at different stages of life. Let's say if a small child is diagnosed at a very young age, usually the parents take care of them and they do try to do a very good job. But as the child gets independence and when they go through the puberty, due to the hormonal changes, they often lose sugar control, and then they start the children become independent, and control of diabetes may not be their top priority at that particular time. But however, when they become adults, they're trying to, for example, if ladies, when they want to get pregnant, again, they do realize the importance of sugar control. But along the way, some of the patients actually develop some complications of diabetes. So it's very, very important from the very first go to realize that this is a very chronic disease and somebody can lead a normal life if we convey these messages at a very, very early stage. Thank you.
Thank you, Dr. Sirhan. I think we have an apt person to discuss the journey across the lifespan. We have a person who has had type 1 diabetes for 62 years now. So she was diagnosed as a child, and now she is retired from a very prestigious job in a US embassy. She has a worldwide experience dealing with people, talking to them about diabetes, and also sometimes they might have got a chance to interact with her disease also, not only as a person but also her situations in life with her condition. So I would like to have a perspective from her for the next thing. Usha ma'am, please, what's your take on this journey across your lifespan?
When I was diagnosed, I was actually in Kenya, in a small town. I was born there. So it wasn't even a big city. So I got diagnosed quite late when I already went into DKA. And I had severe pain in the, and I was unconscious, I remember, whole night. And it was a small emergency place there. And the doctor, Indian doctor, he came to our home and he stayed with us overnight. And morning, he said, okay, she'll live, but she has type 1 diabetes. At that time, and also in a small place, nobody knew that a child can, I was losing weight. So somebody pointed out, and that's how it got detected. And then I saw many, I heard many discriminatory things, like anybody coming home, how's your sick child? Nobody would call me by my name. Or once I heard somebody joking, oh, you have 3 daughters and 1 son. We would like to take one of your daughters, but not that one. And this person didn't know I was in the, I could hear him. So all that, it makes, I had such, I didn't mind my father who used to give me injections because my mother didn't have the heart to, but I somehow that frustration or whatever was in me, and I would hide and eat sweets. So every year I would go into 2 or 3 times into DKA because I heard all that. Till I didn't have a hypoglycemic episode till I was 12 years old, and when we moved to Bombay, and I started taking care of myself. So I was always going into DKAs and all, because I was overeating, overindulging, just to maybe fight back, or I don't know, rebellion. I don't know what my mental state was. And only when we moved to India that I first experienced what a hypoglycemia is. That's the time I started. We had started with porcine and bovine insulin in Kenya. Then when we moved to Delhi, Bombay in 66, I was under the care of Dr. Dirwani. Unfortunately, he also passed away after some time. But that's the time I had big swings, very low sugars, not getting up in the morning for school, passing out in the school. Teachers didn't know what the problem is. we didn't have a doctor. It was a Christian school, but no doctor there. So they would call my sister what to do, and they'll give me some sweet coffee and maybe I will get revived. Once I'm just telling that because this was what I went through. Once I was brought home, carried by four, it was a co-ed school. Four boys carried me on a chair because we were on a first floor, and they left me home. Because teachers didn't know, doctors didn't share any knowledge. Nobody knew. I didn't have any education except that don't have sweets. That's all. How the insulin works, how it, and of course, sorry, there was nothing to test. We had that Benedict solution, put 8 drops of urine and see the color change. So that was a very vague way of knowing where you stand. Blue could mean even 50 or your kidney threshold. After that, it could be maybe 170, 180, like that. So till I think till 76 or something, till 75, 70, we were using glass syringes till 70, 65, no, 76, glass syringes, sterilizing them after I used to carry glass syringe to school, and some students came by and said, oh, she's taking drugs. So all that. And then, of course, disposable syringes came. That made life a little easier. And the most important was when I got my first meter, I think in 1988. At least that showed me which way I was heading. Otherwise, it was always guesswork, swings up and down. And Professor Ahuja was my first mentor. He could judge without my saying much, because all that trauma in Bombay affected me very badly. I went into deep depression because I blamed myself for what I felt. I couldn't express it, so it was all inside. So he understood that, and he would see that my sugars are very, he said, you are a very brittle case. So he would admit me every time I needed admission. And he also, he was a mentor, he guided me. Like I got my first job while I was under his treatment. And even there, after my graduation, I joined the secretarial course, but I had done half of it when, again, I went into very high sugars. So he had to admit, so I had to leave the course and then I had to redo it. But then I passed with first class. And my priority in life was to be financially independent. So I started looking for a job. And of course, there was discrimination again in workplace and marriage and all that. But my priority was to work and earn. So I financially to be independent.
Yeah. One question I have at this point of time, it's been very interesting listening to how things have gone for Usha ma'am. I really understand looking in a country like Kenya and then coping with type 1 diabetes in an era when people were not really exposed to type 1 diabetes is extremely distressing, I admit. So in that perspective, what would be Vishnu's understanding about the role of social media in type 1 diabetes? How much do you think social media has improved or has fueled parent and patient fears regarding living with type 1 diabetes? Your perspective on that?
Yeah, social media is a relatively new phenomenon. So in our country, probably for the past 10 or 12 years, we have an outburst of this smartphone revolution, and almost everyone has got nowadays access to internet, and even if they don't have access to insulin or they can't buy insulin, they must be having a smartphone in their home. So this, I think, has helped a lot. Many of my patients I always make it a point to give my personal number to type 1 diabetes patients, especially because I know as most of our country, at least it's children who are affected with type 1 diabetes, especially in a lower socioeconomic strata. mostly it is children who are affected with type 1 diabetes, who are facing much of social stigma, and they get so much of misinformation from their peer groups, their neighbors, other practitioners who don't have a proper idea, alternative practitioners who don't have an idea about the types of diabetes actually. So they all give misinformation. Sometimes they might be actually trying to help them, but unknowingly they must be harming them. So I try to, at least in the initial part of the times, I keep a contact with them. Mostly I use social media for that. And second thing is that a source of misinformation. So much of forwards and business oriented programs are happening in social media all the time. Marketing techniques are happening all the time. So in the sea of those misinformation problems, we as qualified doctors and qualified modern practitioners, endocrinologists, diabetes supposed to. That's my take on that, Nagesh sir.
This one is for Dr. Siruvan. I specifically want to ask you whether any of your patients have actually traveled to India in the past couple of years for stem cell therapy, newer pancreas transplantation, or any such techniques, because we get a lot of patients from the Gulf who actually come to a few doctors in India for the so-called islet cell transplants, and stem cell transplants. I've seen patients spend a few lakhs, 10, 15, 20 lakhs on the so-called stem cell transplants. Is especially a common phenomenon in the Gulf. Your take on this, Dr. Siron, have you come across such patients from all these?
So far, I have not come across anybody who has gone to India to get this kind of treatment specifically. But just now, Dr. Vishnu has mentioned about social media. I would like to point out we are actually now using social media to spread awareness about diabetes. So there's positive points and there's negative points about social media. So we have to embrace the good points and also keep in mind about the negative things. So speaking about your question, there are a lot of patients who do ask me about, doctor, I want to find a cure for diabetes for me or my child. And I have Googled, or I have come across in Facebook that there's such thing as islet cell transplant, pancreatic transplant, artificial pancreas. And I do try to clarify them, and where, of course, in the West and in some developed countries, there are some indications for islet cell transplant. And also there is a lot of scope in this area, especially in regard to these closed loop insulin pumps. And what I notice is they have a feeling that if they put an insulin pump, their blood sugar will be controlled, so it's kind of taken care of. But I do tell them, I have few patients who actually put on a pump, but they are unable to cope with it. And then when they go back to multiple daily injections, they do much better job. So it's not just about the technology, and it's all about self-empowerment, self-management. I do tell the patient, how often can you come to see an endocrinologist or a doctor? It's not much, but you are living with diabetes every single day. So it's your responsibility to learn about diabetes. And as endocrinologists, as doctors who treat with people with diabetes, it's our responsibility to encourage them to manage things on their own. This monitoring of blood glucose, charting it, is actually not for the doctor, it's for you yourself. You have to learn what food to eat, how to adjust your insulin. And this is so the whole point of today's, I think, talk is using insulin, adjusting the insulin based on the food activity, and learning how your body works with insulin, how body works with certain type of food based on our cultures, based on our preferences. So learning your own body, how to manage diabetes on yourself, that is the way you can lead a normal, healthy life with type 1 diabetes, just like anybody else. So I tell them there's nothing you can't do there shouldn't be any limitation. You should be able to achieve and embrace all your life, your ambitions, and it should be possible. So I do encourage this from the first time where I meet all these disappointed parents and patients. They may be actually in the school, they may be like 10-year-olds and 11-year-olds. I do tell them, don't worry, you will be able to if you face it. Thank you.
Thanks a lot, Dr. Sivan. This question is specifically for Usha, ma'am.
Thank you.
For a lot of diabetics, especially now that we are understanding that the age of diagnosis of diabetes is going lower and lower, the school plays a very important role in the management of, in maintaining your the atmosphere, maintaining the Milo for you. Because on an average, there are many people with diabetes who would actually spend 10 to 12 years in the school before they go on to college. And it's been my personal observation that school support, at least in South India, is not optimal. It's very lacking as far as many teachers, even when we tell them repeatedly, do not take even basic responsibility for their students. It's changing now. It's not what it was maybe a decade ago, but it's been changing now. But I still find that school support is still suboptimal for a lot of our diabetes patients. Even the fact that they spend at least a decade in school and most of the day is spent in the school. So what is your observation? Because you are associated with so many support groups. What is your observation about schools? How was school support during your time, and how do you think school support has changed over the past couple of decades?
During my time, there was no knowledge, so there was no support at all. Even teachers didn't know what's happening to me or what should be given. Like, as I said, once she asked my sister, she said, give her sweet coffee, and the teacher gave. There was no knowledge, there was no help, there was nothing. But now what I hear from, some groups, that some schools are cooperative and they take on when the parents go and interact with the teachers. Some of them take on the responsibility of, okay, we'll give the child a shot maybe at lunchtime, very few, or let them eat at what time they need, but still it is very few. As per the group's interaction, I see that it's still lacking. All schools, definitely not only few schools are maybe following. Otherwise, they ask the parents to come during lunchtime and give the shot. Like, they don't want to take the responsibility. Or if they have a low sugar, maybe they tell them what to do, but all are not compliant. That's what I got. From other.
Yes. Thank you, ma'am, because that's been our observation. The extent of parents' schools cooperation has been to allow parents to come to the school at lunchtime to give an injection. One area where I've had a lot of patients who hypoglycemia is a part and parcel of your youth in type 1 diabetes. There have been many instances where we have tried to teach the school teachers or the headmistresses to give them a shot of glucagon. Many a time we have come up a problem. Some people do, some good people do, especially there are a few teachers whose children themselves have type 1 diabetes. Especially I've seen this phenomenon. If you've got a teacher in school whose child has type 1 diabetes, then it's more likely that they are going to be amenable to this. But otherwise, very few teachers actually even agree to give glucagon. I understand their concern. In case something goes wrong and the child has a major event or there is some death, they don't want to be blamed for that. That's something I understand. And I totally empathize with them, but somehow I found out that schools are not very congenial to even admitting children with type 1 diabetes. 5-6 years ago, even getting an admission for a child with type 1 diabetes used to be a problem. I think that is much better nowadays. What is your impression about it, Dr. Sirohan and Maldives? Do you have any school-based projects for educating people?
Geographically, Maldives is a very scattered country. We have like about 200 islands where people live, and then some islands only maybe 500 people are living, and then there is a possibility that one of the island has only one type 1 diabetic patient, and then it's going to be very challenging. And sometimes even bigger islands in a school, there may be 1 or 2 type 1 diabetic patients. So it becomes a very big challenge in addressing the hypoglycemia. And then they have these physical education classes where they do some sports. And sometimes these patients are not taught to take a carbohydrate or adjust insulin. So they do go into hypo quite often. And we are trying to educate the schools, and we make an attempt to get to these school teachers and try to teach them through various public forums. It's not easy job, but I think it should be possible if we try in at least in Maldives.
Thank you, Dr. Siruvan. And Vishnu, your impression about schools in Kerala, the most literate state, are they
Yes.
more helpful?
Yes, I have my daughter who is now 6 years old. She is going to second standard. So I have talked to a private school where I think they're all modern. They have a modern approach. They don't scold their wards for not being too competitive. I like that much. So that's the most important thing, that children are all different, and they recognize this fact that children are different. But I think that is one exceptional school, and most other schools are of the normal variety where they are madly running behind grades. So I don't know where the actual situation, how much because I have been far away from Kerala for past many years. The past 10 years I have not been in Kerala. So probably I'll get to know more if I continue here for some time more.
Thank you. And one other question, especially given the amount of focus we've given Usha ma'am's fact that in spite of being through 6 decades of diabetes, she hasn't developed micro and macrovascular complications. I've noticed that a lot of people with type 1 diabetes actually don't focus a lot on the complication aspect. They only focus on hypoglycemias and diabetic ketoacidosis. And we've been taught from time immemorial in school days that diabetic retinopathy and diabetic nephropathy are like promotions in a job, in a government job. Whether you work or whether you don't work, you would promote it, irrespective of how good your control is. After 20 years of type 1 diabetes, you're almost invariably going to get diabetic retinopathy. When I come into practice, I've actually seen that this is not true. I've seen many people with even 30, 35 years of type 1 diabetes hardly having any neuropathy, nephropathy, or retinopathy or cardiovascular complications. I've seen people with diabetes for only 4 to 5 years, especially the poorly controlled ones, presenting with severe retinopathy and incipient nephropathy. Your observation on this, Dr. Sirovar, your experience with complications, how has there been a change in the pattern of long-term complications with type 1 diabetes, and are patients and their parents really bothered about long-term complications?
What I have come across is the long-term complication is least of their bothers. But I'm not sure if we are not paying too much attention to hypoglycemia, but I have seen a lot of patients suffer because of hypoglycemia. I think one of the biggest barriers for their blood sugar control is also hypoglycemia, because they are sometimes the insulin regimen is designed such a way that it's not very compatible with the patient's eating pattern. So they go into this hypocres. And even especially school children, when they go into hypoglycemia, they have headache the whole day. I'm not sure if they even recover from this hypoglycemia within 1 or 2 days also. And I've come across patients explaining this horrible experiences because of hypoglycemia, and then they're skipping the insulins. So they are not actually proactively many times asking me about chronic complication. The most common complication which I have come across is actually neuropathy. A lot of my type 1, few of my type 1 diabetic patients have these neuropathy complications, but not many of them have retinopathy or nephropathy. I have not seen many of them having these complications, but a lot of them do complain of neuropathy, and we do work them up for other causes. But so far, in regards to type 1 diabetes, I haven't come across people who are suffering too much with the chronic complications. But
Can I ask one question?
yeah.
Yeah, because you have brought about this thing about hypoglycemia. I just want to ask you, is technology helping you in Maldives? We now have this option of doing a flash glucose monitoring, which you call a continuous glucose monitoring, which is now available for in Indian rupees. If you say 10,000, I don't know how much it will come in Maldives. So it will. It's for a fairly low amount that you'll be able to nowadays there is a huge stunt being happening in even in big countries like United Kingdom, where they're offering glucose monitoring for every type 1 diabetic patient through National Health Service. So what's your take on offering all type 1 diabetes patients at least a continuous glucose monitoring? Will that help in avoiding hypoglycemia?
Yeah, it will help very much. In fact, I have asked a lot of patients to get this flash CGM from India. Actually, they most of them get it from Kerala, but somehow we don't have it available in Maldives still. I mean, despite all this time, it's not easily available, and COVID was not helping either. So I'm actually emphasizing a lot on patient about that. Part of your sugar control depends on how good you do monitoring and avoiding hypoglycemia. So even at the moment, actually Maldives have this social insurance scheme where almost every medical aspect of healthcare is covered, and the government has even started covering insulin pumps for some patients. But the thing is, the glucose monitoring has not been that well covered. Even the blood sugar monitoring, they are not covering under these schemes. Even the simple glucose strips are not being covered. So it's a huge burden. So people are kind of rationing. They are like avoiding to check much because to reduce the cost. Insulin is available free of cost for all of them in Maldives. Even the modern all these long-acting insulins and short-acting, rapid-acting insulins are available for free, including the needles. But monitoring is expensive, and I have suggested a lot of them to get the flash CGM, but it's not easy to get the. It's not about the money; it's actually affordable for most of them, but the accessibility is not there at the moment.
At this point, I'd like to butt in and ask Usha ma'am.
Yes, please.
One question. This is a double-barreled question, actually. The first thing I wanted to ask you was, how have you managed to ensure that you have stayed 6 decades being diabetes-free? The second question was, puberty during the lifespan is a very difficult period for most people with diabetes, especially girls. They have a lot of social aspirations. They have huge emotional upheavals because of the fluctuating hormone levels. I've seen so many girls skip doses during puberty. Puberty is one of the commonest times when girls who are actually been well controlled, even boys who are well controlled, suddenly start developing poor control and start developing ketoacidosis. What is your take on this? How have you managed to do it in such a successful manner?
I don't know. I think God has been kind to me because nothing was going right, really. And you're right. When the puberty sets in, then the hormonal levels go up and down. That's the time I think I went into deep depression also, because we had changed countries, and people would remark, like they wouldn't understand what she's going through, or just say offhand, you're doing this, why are you not talking, why are you this, and all. Yeah, it had a effect on me, but I would say I didn't have the best control till I got a meter. Even now they say my diabetes is brittle, so I think somehow God has been kind that, but now ever since after meeting Dr. Ahuja and all, I keep a proper log. I think every patient needs to keep a proper record. Even a doctor can't help you without that. And I write the all the details, what I've taken, what I've done, what activity, what food, what chart, what made a difference. Now I follow that very, very religiously. But those days were difficult. Yes, my sugar would shoot up during exams, and I would blame myself. Why I did poorly? I was supposed to get a first division. What did I do? That time there was no knowledge, there was no help really, because I was clueless. Not even doctors educated anything. Like they treated, but there was no education. I mean, they would say, take this shot, and that's it. I wouldn't get up in the morning because of lows. There was no education at all, either from the medical point of view, or from schools, or from, there were nobody else I knew who had diabetes. So I was clueless till I came to AIMS. That was 74. So I would say I've been lucky, maybe.
Thank you, Shaman. So I had one question to ask Dr. Srinagesh, sir. Sir, do you think the paternalistic view of doctors are nowadays changing in our country? Do you think we need to involve more of our patients, and especially in type 1 diabetes, their caregivers in their management? Are we doing enough, or do you think there is a lot more to be done?
Define paternalistic.
No, I am not asking specifically about you, sir. I just want to know whether.
What exactly do you mean? Look,
I was thinking like we as doctors, many people who I was reading another article about patient perspectives on diabetes management. So one common area of concern from the patients is that doctors don't actually think that I am the person who is traveling this journey, and I have a contact with the doctor for 8 hours, probably in 1 year, but remaining 8,000 hours of an year, I have to manage the condition myself. So that sort of an awareness, do you think the doctors have enough, and are they just giving the directions to the patient and expecting them to follow that? Or do you think we are at a stage that we are more into a teamwork with our patients? I am asking you about the general practice in our country now.
I'll tell you two things. There are mistakes from both sides. On one hand, from the doctor's perspective, it's true that a lot of patients, a lot of doctors don't realize what the patients are going through. Because I'm not even talking of, I'm not saying that doctors are not unempathetic. For us, we know for a fact, if you're a good endocrinologist, you're a qualified endocrinologist, you know for a fact, the type 1 diabetes is not a very life-threatening disorder at this point of time. It's not a very dangerous disorder. There are very good treatment. There is very good treatment for that. The costs have also come down. It's very easy to maintain a very good lifestyle, free of complications, free of hypoglycemia, with just a right use of technology. So we don't think it's a very big deal. We don't think it's a very major problem from a medical perspective. We are entirely looking at it from a medical perspective rather than from an emotional perspective. I think this is something we have to understand, that patients also go through a huge amount of emotional trauma. So it's always better that we advise them to take support of really good peer groups. Again, I'll be very particular about it. Peer groups, again, in type 1 diabetes are a double-edged sword. If it is a good peer group, the kind of things which we have seen as part of our Endocrine Society Type 1 Diabetes Initiative, where they take care that they don't spend misinformation. Dr. Usha, Mr. Rajiv, all these people who've been working, where they give you only the right kind of information, it can be a huge pool. But if you're in the wrong kind of peer group where you get every WhatsApp forward which gives you a miracle cure for diabetes, then it's going to be a huge problem both for the patient as well as for the doctors. That's one end of the perspective. The second part is patients have to understand, and unfortunately, this is again one area where technology has played a very bad role. I've seen very good doctors support for patients with type 1 diabetes, where they only help them with during times of emergencies and help to empower the patient. I've again seen other kinds of type 1 diabetes, doctor groups, where the patient is literally enslaved to the doctor to a smartphone. Every time you eat something, you're supposed to take a photograph, send it back to the doctor. The dietitian calculates, tells you what to eat. Every time you have a blood glucose reading, you're supposed to send it back to the doctor. The doctor tells you how much insulin you're supposed to give. These kind of groups definitely are not the right kind of groups. They're only going to end up enslaving the patient to the doctor. This is done only with a commercial intent. There are a lot of apps in the market right now which tell you that you are going to maintain a 24/7 contact with the doctor. Nothing can be more disastrous for the patient. If you are a type 1 diabetes patient, you are meeting your doctor to fine tune your insulin dosages, to discuss specific problems with you. If you have any other issues like hypothyroidism, and to look for other problems like sexual disorders or diabetic complications or growth problems. Beyond this, the doctor only has a supervisory role in the management of type 1 diabetes patient, because as you have rightly said, he is going to live with it for the rest of his life. So it is up to him to manage diabetes. He has to take the lead. But unfortunately, what I've seen with a lot of patients and parents is, even if this sounds a bit harsh, a lot of them give it to self-pity. I know it is a very difficult problem. Type 1 diabetes is not an easy thing to have, at least in a child. But you cannot do anything about it. You can't turn back the clock as far as type 1 diabetes is concerned. The beta cells, once they are gone, are gone. We have had so many studies, the Brazil study, nothing has worked. Antithymocyte globulin, azathioprine, nothing has worked. Once type 1 diabetes is there, type 1 diabetes is there for life, and you'll have to learn to cope with it. But think of what happened to people with type 1 diabetes a century ago. They would eventually die. Now what happens? You can lead a normal life free of complications. Only thing is, you should not give in to this feeling that you're helpless. Start utilizing your insulin, start utilizing your resources properly. Learn to communicate with your doctors, and most important, do not be afraid of testing. Almost 95% of the problems which happen in type 1 diabetes happen because they don't want to do self-monitoring of blood glucose. If you do a proper self-monitoring of blood glucose, most of the disasters with type 1 diabetes can be avoided. I know it is difficult for parents to keep repeatedly pricking their, doing skin pricks, checking. It is painful. I understand, but we don't have an option. We are getting new devices. CGMS devices are good, but they're not yet foolproof. You still have to corroborate a low blood glucose level seen on a CGMS, which are glucometer. CGMS has definitely cut down the number of skin pricks or number of pricks, blood glucose pricks you do in a day, but it is still essential. And when you monitor, in fact, a lot of our endocrinologists also have this feeling that the kind of insulin doesn't really matter if you monitor properly. And you learn to take your insulins at an appropriate time. Even if you use a recombinant human insulin, even if you use a bovine insulin, or even if you use the ultra short acting insulin, the final result remains on how well you monitor your blood glucose levels, how well you treat yourself, how much you don't listen to your neighbors and friends and WhatsApp experts, and you have to take decisions. Many doctors have this habit of discouraging patients from reading about diabetes and talking to them. I think this is wrong, because however much we try, we cannot read as much as a patient is going to read, because it is their entire world for them and they're going to read about it. But at the same time, patients also have to understand and use their discretion when they discuss newer advances with patients. If you discuss every WhatsApp forward, then your doctor is not going to entertain you the second time. So I think we need changes, and we need changes on both sides.
Yes, regarding that, that's a very important point, sir, what you have made. I think regarding the point which you made about peer groups, do you think there should be a way that all these there are so many of peer groups in the country, and you said that peer groups, some of them are giving good advice and some are not up to the mark. So do you think there should be a way that, like, for example, in Endocrine Society website, we know, or in the local websites, we know who are the qualified endocrinologists available in the local area. Similarly, should there be some way in the Endocrine Society website where we can find out which are the good peer groups, where we can refer the patients to?
This is a very good suggestion, but very difficult to implement in practice. Because you have good, because if you start implementing these kind of peer groups, then you are going to face problems from patients who are going to say that these peer groups are being hijacked by only a few people with advantage, people who are already in the know of these things, and they're not letting out their aspirations. A lot of times, these kind of problems can also be brought out by those people who are encouraging this kind of negative peer groups because of financial advantages and because of many other issues. Even in type 2 diabetes, I see for every one good video which is posted on YouTube, you'll find 10 fake videos. Most of them are done with a financial intent. It is these kind of people who are going to face a lot of problems when we start trying to regulate peer groups. It is again up to the parents to understand. But there is a good suggestion in that the really good peer groups can maybe focus more on advertising on Facebook, reaching out to people, helping them out. And doctors can also have when patients ask us, can we go to a peer group? Doctors can also have a major role in directing them to the positive peer groups. That's something which we can do in practice, but in theory, but in practice, it becomes a bit difficult because if you keep referring them to these peer groups and patients do not like what is being, the pragmatic advice being given by the proper peer groups. They can always tell you that you are directing them to these peer groups because you're not interested in listening to their problems. It is not a fact we are interested in listening to their problems, but we cannot encourage the kind of practices which go on in a few peer groups. Usha ma'am's opinion on this. Have you done anything to reach out to people with type 1 diabetes, ma'am, with respect to positive peer group advice?
Yeah, no, till last year when I was working, I didn't have time, sorry, to really join. But now with Dr. Shrikanta in Bangalore, I was in touch with them. He was the one who awarded me the gold medal on completion of 50 years. So I am in touch with them. And also here we have this Dia group. But I am not so much into, really actively participating, but whoever wants to, they call me, and in my capacity, what I can tell, not as a doctor or anything, but as a patient or what I know, like basic things, I try to encourage them. That's how much I am involved, or I guide them. They should ask their doctor or whatever, or their dietitian, like that. I speak to them, and some call for some moral support just to be, and they want to feel they're depressed or because a child has it and they can't cope. So I just give them some encouraging talk. I try to pep them up. That's my role. Otherwise the treatment and all, the doctors have to decide. We can't tell them what to take, how much insulin to take, and what to do. I wouldn't go there.
One question for Dr. Siruvan. Your experience with any peer groups in Maldives? Technology?
Yeah, there's a Diabetes Society of Maldives, and they do have actually a very active peer group. And they were even having these diabetic youth camps, which was helping a lot. And then they were even inviting international patients to join the youth camps and share the experiences. And I think most of the outcome which came out of that peer group was positive. And we do even have yearly youth camps they kind of organize. So there were, of course, existing group of diabetic patients. And then every year we have new graduates, like new diagnosis. There are like at least every month we are getting, because Maldives is a very small country, but every month we are getting at least 2 or 3 new diagnoses. That's like quite a lot, significant in Maldivian standards. So they get recruited, and then we try to train them about mainly empowering them for self-monitoring. And we do not have too many peer groups, luckily. So it's very few at the moment. It's usually most of the patients are under our National Diabetes Center in IGMH, and some of the patients are under Diabetes Society of Maldives. But apart from that, I don't think there are independent peer groups at the moment.
Thank you, Dr. Siruvan. I think that's actually a very good suggestion, what Dr. Siruvan and Dr. Vishnu have said. In the future, if you have patient information resources on the ESI website, we can perhaps make space for links to a few of the better known and better controlled, better directed peer groups. So that at least in the first couple of years of diabetes, before type 1 diabetes, before the parents and their children actually become used to having diabetes, they can be handheld and perhaps be led to more positive outcomes. Because peer groups definitely are a great help. Even in finding out information where you can get insulin, where you can get glucagon, cheaper sources of technology, cheaper sources of pumps.
Yeah.
A lot of times patients actually know better than we do. I think this is actually a very good suggestion for most of us.
May I say something?
Yes, ma'am.
Yeah. I feel being connected to Dia, I've seen that many patients benefit, like they try to tell from different cities, they ask where is Humalog or which insulin is available where, like they guide people, and many people are helped like that. And also they made a list now which hospitals give out free insulin to poor patients. So that is again something very useful to poor people, can at least go and get avail of insulin. And I feel government should really do something about cost factor is still there, I feel, for good diabetes treatment, and something should be done to control the ever rising cost of insulin strips. I'm not on a pump, I'm on MDI, but I feel more people could be helped by some kind of control over the cost or help.
Very true, man. Not only about the cost of the pump, but also not about the cost of strips.
Yeah,
but also
strips.
Quality of glucometers is a major issue for a lot of us today, right? Quality of glucometers has been a major problem for me.
Yeah.
Many glucometers actually don't give you the correct values.
Yeah, I have to, and they give different readings. Yeah, true. Yeah.
I think US had this program called Strip Safely, right? I think we need to have a similar program in India also. But again, that has to be a government initiative. It cannot be a society.
Yeah, the government should take initiative. I think there are many things we need to get done. But yeah, even informing, I think, like general public, like maybe now we have more groups, but I feel that the lay people still don't know. When you talk about diabetes, they think type 2 diabetes. They can't connect type 1. No, I mean, nobody has helped me till, I was just telling before you came on the scene, that nobody has ever helped me in a hypoglycemic state, because simply nobody would open my bag and read my card. They don't know. They say type 2. Type 2, आप बहुत sugar खाते होंगे तब आपको diabetes है. Like, no, they don't know. In all the places I've worked, none of the employees really knew, Indian employees, Americans did, that what a type 1 is. You have to take insulin, you have to take you can eat an orange, like that. So when they know that you can't eat sweets, you can have fruits, like that. People are not aware. General public is not aware, I feel.
That is very true, ma'am. In fact, I think just a few days ago, we had this discussion that Mr. Suresh Gopi was actually one of the first people to raise this issue in the parliament about type 1 diabetes. Right? So hopefully things are changing for type 1 diabetes.
Yeah.
And in future, we'll probably have a national type 1 diabetes program also on the lines of the national diabetes program.
Wow.
Hopefully, we'll end up having a national type 1 diabetes program. At this point, I think we have a few questions. Do we want to answer these questions, some of us? We got a few questions from the audience. You want me to take them? Because I think we are reaching the end of our talk session. We have a few questions. One question from Mr. Rajiv is, insulin Isotech, which is under trial, can it be used by type 1 diabetes? Your comment on this, Vishnu?
I'm not heard.
Yeah, that's a once weekly insulin, and I had read a paper about that once. That's all. I don't think it's available now, and I have not read about it in use in type 1 diabetes.
So I'd like to answer this. Isotech at this point of time is being tried out only in type 2 diabetes. Type 1 diabetes, it will still take a lot of time, because type 2 diabetes, you go ahead with the assumption that they still have some amount of beta cells left. And there is a background insulin secretion, and once weekly insulin is likely to work in this. Type 1 diabetes, the dynamic is very different. They have lost both first and second phase insulin secretion. It's not so easy trying to manage people with a once daily basal insulin with isotech. And as all of us know, a lot of trials usually start with type 2 and then they progress to type 1. Then they progress to the younger kids and finally to pregnant women. So I think by the time we get a positive conclusion or some conclusion of the isotech, it will be at least another 4 to 5 years before I think we can give you a proper answer to this question. Right now, it's restricted to type 2.
So may I ask one something?
Yes, ma'am.
Yeah. What's your take on Tresiba insulin?
This personally, yes, I have found it pretty useful even in young type 1 diabetes patients. A lot of times with the other basal insulins, I had this specific problem where you take the insulin at around 9 p.m. at night. Children metabolize insulin much quicker than adults. Most of the time, they take their insulin at 9 p.m. Next day morning, fasting insulin is taken with breakfast. They have their lunchtime insulin at around 1 p.m. Come back home at around 4:30, have an evening snack. And most of them actually end up skipping their correction doses. Then insulin, true 24-hour insulins are very rare in children. Whatever nighttime insulin, basal insulin you have taken stops working by around 5:36 in the evening. So between 6 p.m. to 8:39, they have very little insulin in the system. And it is these 3 hours which drive your blood glucose levels all through the night. And you wake up with very high fasting blood glucose levels. This particular problem to some extent has been addressed by Tresiba because it is a true 24-hour acting insulin. We have found less glycemic variability with this insulin. We've been using it. Personally, I've been using it in a lot of children. It's now even licensed. Your take on this, Vishnu? You've been using this?
Yes. No, I have been using this in type 2 diabetic patients, and I have found it very useful especially in patients who have just like that very high fasting blood glucose values and all. My patients, regrettably, I have got all who have not that much of affordability till now, type 1 diabetes patients. So I have not gone to the newer analogs because I think about their long-term problems. I don't want to offer them something which they cannot take their whole life long.
Even in Maldives, I have used for few patients. I've started practicing in Maldives for last 3 to 4 months, and I have given for at least for 4 or 5 patients, and it has helped them a lot. And it's actually free for them. But the issue is the availability. So I'm actually sometimes a little bit worried. Suddenly this will run out of the country because not many patients are using it here. So if a pharmacy stops bringing it suddenly, they might need to again order from India. So that's the issue, but it has helped a lot, reduce the glucose variability, which reduce the hypo and on the long run improve the glucose control. It has made a huge impact for some of the patients which I have used.
Okay, I wanted. May I ask something? Yeah. Shall I?
Please, ma'am. Please.
Yeah. Like mine is very brittle control. So, and I'm taking Lentus. Do you think Tresiba would help better, generally speaking?
That has to be dealt with on a patient-to-patient basis. Ma'am.
Yeah. Okay.
Brittle diabetes, the first thing you'll have to do is a continuous glucose monitoring. Once you do it PGMS,
no, I do that.
You're going to get an idea of how brittle it is, what's going to happen.
No, that's helped. Yeah, you're right. After my CGM, at least I know where I'm going. It is
just one point to note here is language. Using language in diabetes mellitus, it's all an era of political correctness. But still, I think language matters in type 1 diabetes. So sometimes these terms like control and poor control or brittle diabetes, all these terms are actually derogatory. That's what the people in advanced societies mention. So then they don't want to mention these terms. I just put it out as this thing. So we just tend to give a name to the patient. Previously, they used to do that. Somebody used to write WOT, waste of time, on the patient's case file. So such sort of derogatory terms should not be. Brittle diabetes is also actually something like that. It just means that they have a high hyperglycemia sometimes and hypoglycemia sometimes.
No,
so, but this term, Yes, ups and downs. That's what.
Hmm.
But that term should not be used, I think. What's your take on that?
But how to express it then?
I don't know.
A lot of times,
We have-
political correctness doesn't give us alternatives. One question I wanted to, this was for Vishnu and Dr. Sirohan. There are some people with type 1 diabetes and gender identity issues and overlap with type 1 diabetes. Have you had any experience with this?
Sorry.
Even
I don't have any experience with that.
Dr. Sirohan, any experience of gender identity issues and overlap with type 1 diabetes?
None. So far, none.
Same answer from me. I think we'll have to include this in some other session because none of us have actually had an experience with this particular phenomenon. One other question for both of you. This was from another viewer. He was asking about, do you have any particular score for prediction of nocturnal hypoglycemia? As far
Is
as
there any score?
is there
I
any
don't know.
score for prediction of nocturnal hypoglycemia? I don't think there is any such score.
I think I have read about a score of hypoglycemia somewhere.
Yeah.
I don't remember that, but there was some paper giving a score for now, and I
There's
don't know
score
whether
for
it is for
prediction.
prediction. I
It's
don't know
not for
whether it is for
prediction.
prediction.
It's
Yes.
not for prediction. There is a score for hypoglycemia, but at the end of the day, hypoglycemia is essentially academic. If you have it, you have it. You don't start scoring it, you immediately give them some relief. Because when not treated in time, it can have major manifestations. So, what I tell my patients is, if you have hypoglycemia, don't wait. Check, eat.
I think
you were saying.
I think from this continuous glucose monitoring, we have something called a time below range, which might be used to predict nocturnal hypoglycemia.
And one last question I think we had from one of our viewers, a very important question. Obesity with type 1 diabetes, how do you tackle this phenomenon? I think this is becoming increasingly common nowadays.
Yes, there has. So type 1 diabetes patient, once they are given insulin, they are not different from, they are in no way different from any other person. So once there is only one thing that they lack insulin, they don't have that relationship between glucose and insulin. So that part is off, and we are taking care of that part. Otherwise, they are all prone to develop all the problems affecting any other person. So obesity is a common problem nowadays. It's not specific. It cannot be restricted to only for type 1 diabetes patients. So there has been some studies which have offered treatment like type 2, the treatment which we offer for type 2 diabetes patients, use of metformin, use of SGLT2 inhibitors, newer other drugs which we use in type 2 diabetes. They all have been tried in type 1 diabetes patients also, those who have diabetes. I think I have also some experience of using metformin in patients with type 1 diabetes. I have not used any other drug in type 1 diabetes with obesity, especially. So I found it useful, especially during the pubertal periods where they have more of insulin resistance.
I think type 1 and type 2 diseases, diabetes are two different diseases. So just because you get type 1, you will not be protected from type 2. So, so if you have family history of type 2 diabetes, you have genetics, your racial background, you may get type 2 diabetes phenotype. And then it becomes very difficult to control certain time. So as Dr. Vishnu mentioned, we oftentimes have to use type 2 drugs even in type 1 diabetes to address this insulin resistance and obesity. So I think it is a very valid point. And we are seeing these kind of patients increasingly commonly.
I have a slightly different take on this. In fact, if you looked at the search database, which was a study in patients with type 1 diabetes in the US, which was a very large study, which had almost 15,000 subjects. They found out that approximately 5 to 10% of all the children in this search actually had acanthosis nigricans, were overweight or obese, and a lot of girls actually had polycystic ovarian syndrome. This was one of the first studies which brought across the idea that it was possible for type 1 diabetes children to have manifestations of type 2 diabetes, which is very interesting and which, like Vishnu and Dr. Sirohan have said, is something which needs to be looked for in people with type 1 diabetes. On the flip side, I have always had one question about this. How were these people actually classified as type 1 diabetes? Did you do the antibodies? Did you do any of the C-peptide levels? Were some of these people actually people with either type 2 diabetes or monogenic diabetes who were misdiagnosed as type 1 diabetes? That's always a question I've had whenever I looked at the search database, because obesity is becoming more common in type 1, but it is still quite uncommon. It's not as rare as it used to be, but it definitely is not very common. So are we misdiagnosing it? Are we missing something here? Because whenever I read about the mild forms of single gene disorders of diabetes, like monogenic diabetes, we always have this quotation. There is nothing on earth which prevents a person with glucokinase deficiency to eventually develop type 2 diabetes. At the same time, so are we looking at a phenomenon where, because generally I've seen that anybody over 30 is always labeled as type 2 diabetes, even if he has type 1 diabetes. The converse is also true. Any person below the age of 15 years who walks into the OP with high blood glucose levels is automatically labeled type 1 diabetes and started on insulin. Except a few, except endocrinologists, nobody is actually looking out for monogenic diabetes. They're not looking at type 1. They are not looking at type 2 diabetes, especially with the lockdown and so many children being at home and gaining weight in the past 1.5 years. Type 2 diabetes has become a clear and present danger in a lot of schools. So are we missing a lot of other variants of diabetes and mislabeling these people as type 1 is one question for which I don't have an answer. And we need a large scale study before we can actually say that the obesity is increasing in type 1 diabetes. It is increasing, but is it the only problem is something I don't think I can give you a clear answer on this. We are definitely misdiagnosing a few type 2 diabetes as type 1.
Also, this, I think type 1 and type 2 diabetes is very much oversimplifying diabetes itself, isn't it? I mean,
yes,
very
absolutely. We have only two broad groups. We don't have shades of gray. We've got only black and white. You're either type 1 or you're type 2. I think that attitude needs to change among doctors as well as patients. And that can only be brought about by more awareness about this entity. So we're getting reminders from our overlord that the program needs to end. Mohan Shenoy. This has been an excellent program, actually. These kind of discussions, I think this is a unique program for most of us here today. And it's been a great pleasure having Usha ma'am here. Great pleasure having Dr. Tiruhan. Hopefully someday we'll also come to Maldives and all its beaches, like most of the Indian actors seem to be doing in the last 1 year.
Yeah.
And Vishnu, as always, is a pleasure. And Mohan,
thank you
for all the excellent work he's done over the past 1.5 years to 2 years in ensuring that we have such good programs. And a big thank you to all the audience. Thanks one and all, and thanks to Mintu for the technical support. I'd like to sign off now. Thank you.
I think Usha ma'am wanted to conclude this with her prayer. She had told us that she has a prayer and we'll conclude.
Yeah, it's a prayer which is very close to my heart. God grant me serenity to accept the things which I cannot change, courage to change the things I can change, and the wisdom to know the difference. Thank you.
Thank you, ma'am.
Thank you, ma'am.